Good afternoon, everybody. Welcome to another episode of Samaritans Purse International Health Forum. Just so excited for you guys to be joining with us this afternoon. We've got a great presenter today. As you'll always remember, we have the chat box to your right that we'll utilize for questions and answers at the end. So just encourage you to utilize that as we approach the Q&A time. Before we get started, I just wanted to share a verse with you. Romans 12:12. It says, "Be joyful in hope, patient in affliction, and faithful in prayer." And so with that, let me open this up in prayer. Dear Heavenly Father, just want to come before you today. Just so thankful for this forum, for this technology that we have available to us to educate ourselves to serve you better on the mission field. Thank you for Dr. Steffi's being with us today. Just speak through him. And we thank you in Jesus' name. Amen. So just a real honor for me to introduce to you today Dr. Bruce Steffes. I met Dr. Steffes and his family actually in 2002 when my family, we went on our first medical mission trip together to Tenwick Hospital, and we stayed in the guest house right adjacent to Dr. Steffes and his family, and we're there for over a month there and just had a great opportunity to get to know him better. Dr. Steffes is a surgeon, educator, and entrepreneur with 22 years of experience with surgery in the Global South. He has been involved, if you're familiar with Pan-African Academy of Christian Surgeons, since 2004, and so he comes with just a plethora of great experience and a wealth of knowledge. And today he'll be speaking about successful medical education in developing countries. And so, without further ado, Dr. Steffes, I'll turn it over to you.
Thank you very much. Can we have the first slide, please? All right, the next slide, please. I would love to report that I had a financial conflict of interest, but doing medical missions, that's not true. Here's my email. Many of the topics that we're going to talk about today are going to probably be best on a one-on-one sort of situation. So if you have any questions after the session is over, please feel free to contact me. Next slide, please. The need for medical education is indisputable. And in a time when it's becoming increasingly difficult for missionaries to get visas to do traditional medical work, the medical educator still finds the doors are wide open. Admittedly, this is a different style and a different paradigm from traditional medical missions. It's kind of a marketplace ministry. The window of opportunity for missions is closing, and investing in national healthcare educators who can stay after we're being forced to leave is one way to both multiply the effort and ensure that high quality teaching and the gospel will continue to have a voice. The article that you see there from Christianity Today from January 6th was entitled "The New Face of Medical Missions," and it featured the Pan-African Academy of Christian Surgeons, but it has a subtitle that I think is important. It said, "The missionary physicians of the 21st century will be Africans, and U.S. mission agencies couldn't be happier." The post-residency program with Samaritan's Purse has evolved even in its relatively short existence in recognizing some of these changes and are making things easier for medical educators to go overseas. I have stated on the slide that we will discuss how to achieve success both organizationally and individually. But I'm going to make that statement with several caveats. The first is that every approach to being a medical educator that we're going to talk about requires a different emphasis. Number two, there's really no tried or true cookbook for everyone for creating a successful organization. There isn't a single plan that's going to work for all organizations and all individuals. Next slide, please. I love this slide. As mentioned, the third caveat, the planning to plan and prepare is actually preparing to fail. So that if it's, whether you're an organization or an individual, you have to do sufficient planning, and that's particularly true in terms of medical education. Dave Thompson and I, Dave is the founder of PACS, are in the process of writing a history of the organization that's going to be published for recognition of the 25th anniversary. And today I'm going to be talking about some of the things that we learned that affected PACS and some of the principles that I think can be applied a lot more broadly. Next slide, please. You're all familiar with these kind of slides, and red is bad. And this is a slide that shows the distribution of healthcare workers. And you can see that there are a lot of healthcare workers in the global north and in some areas of the southern part, but there is that 1040 window where there is not a lot of healthcare workers. Next, please. This is going to take that same information and display it somewhat differently. The bloated countries are those that have a lot of people in medical care in preparation, or excuse me, compared to the population. And so you can see here, Africa and some of the other countries that we were mentioning in that 1040 window are very small. Next slide. Many of you have seen this slide. This is coming out of the Lancet study from 2016, which emphasized the need for surgery. And while there is certainly a huge need for surgery, there's a huge need for medicine throughout. You have to question that if I am a Christian healthcare provider, what am I doing to help address this horrible shortage that's everywhere? Next question, or next slide, please. This picture actually came from Keir Thielander's presentation in 2018 on this same webinar. And the dots come from the Joshua project. These dots show the unreached people groups. And so you can see that there's a tremendous overlap between the need for medical providers and for people to hear the gospel. And so as a second reason that a healthcare worker who is a Christian needs to think about this is there's a need for my medical help and there is a need for my witness for Jesus Christ. Next, please. I think what's important is that we as specialists do not need to be zealous in our guarding of our knowledge. We can look for the 80% that anyone can learn and share that. Next, please. The outside of the gospel, it's education, not inappropriate technology. It's not sending some shiny piece of machinery that's important. It's education. It's going to disrupt age-old cultural patterns, though. It's going to change things, and it's going to take a tremendously long horizon and a lot of patience. Next, please. But what I think is very much true for the short-termers that are going out or in the career folks that are going out under the post-residency program, we have to realize that for us to return home without leaving something in terms of medical education is a tremendous waste. Next, please. This slide is also from Keir's presentation from 2018. He and I have been stealing these slides and swapping them back and forth for years, so I'm not exactly sure where this originated. But if you start looking at this in a kind of an artificial platform, there are several groups that are on that left column. There are people who are secular teaching groups, and they will teach anyone. There are a group of Christian organizations who believe that we as Christians should be teaching all peoples of all faiths. And then there are some who are dedicated to teaching just Christians, people of like faith. And each of these has a particular emphasis that they believe is important for their organization. It's important to realize that none of these are right none of these are necessarily wrong. It's what God has called you to do in order to obey him. Now, we've also can take these three different groups and divide them up into short-term and long-term groups. Next, please. Here are some examples of that. For example, in the secular short-term, most of us are familiar with the Médecins Sans Frontières, the Doctors Without Borders, Operation Giving Back from the American College of Surgeons, various universities, Smile Train, et cetera. And they have short-term, and then there are long-term possibilities within the secular world too. These are clearly workplace opportunities. In the groups of Christians Teaching Everybody, the Medical Education International, which is a commission of the Christian Medical and Dental Association, and Prime, which is a British group, do really the similar things, taking university teachers here and putting them into those environments overseas. There are increasingly, from a long-term standpoint, there are a larger number, an increasing number of Christian colleges, medical schools that need professionals to help. In His Image is a well-known residency program. Cure is another one that does that as well. And then we have the short-term, where the Christians are teaching Christians. So World Medical Mission would fit into that category. Again, MEI to some extent, PACS, the CIMS, the Christian Internal Medicine Program in Cameroon, CAP, the Christian Academy of African Physicians, which is trying to start general practice, family practice programs in Africa. And of course, for nursing, mission nursing schools have a long-term need for both long-term and short-term folks as well. And there are long-term opportunities as well under these, various organizations. Next, please. There are certainly truths for cross-cultural ministry that you have to keep in mind. Right now, global medicine is sexy. Programs that have something to do with global medicine are exciting, but the reality is this may well be a fad. This may disappear with time. 3 years ago, I was honored to address the Boston Global Surgical Symposium, and there was a room full of 200 young enthusiasts about global surgery. Robert Riviello and I addressed the lunchtime group on the topic of finding a career in global medicine. Now, while it's unknown whether the emphasis on global medicine will actually last, it is very clear that at least permanent involvement in global medicine requires considerable sacrifice, and finding any sort of a paying job in global medicine is actually difficult. It's usually volunteer or a way of reconstructing your career and your time off and your research priorities that will allow you the ability to use your own money to accomplish anything. I think if you come into this and expect that it will somehow be a well-paying job that's exciting and fun, that's not likely to happen. Sacrifice is real. Next slide, please. You have to realize that it's kind of like the breakfast. The chicken is involved, but the pig is committed. And so in order to really be effective here, you're going to have to make a big commitment for your career. And that means that we're going to have to do some planning about how I can be an effective global teacher through the course of my career. Next, please. Dr. Plyler has asked me to review PACS for you. When you live and breathe and eat something, sometimes you're convinced that everybody knows about it, but I know it's not true. When I was in my business school for my MBA, they pointed out that when you're thoroughly sick and tired of your advertising campaign and want to stop it, the first customer is just noticed. So I'm going to take a few minutes and go through PACS, just a brief summary. In 1994, a group of missionary physicians at the Christian Medical and Dental Continuing Medical and Dental Education Conference at Brackenhurst had a discussion about the idea of creating a real legitimate surgical residency. In 1996, they came back with it, and Dave Thompson stimulated further discussion, and they signed a charter that committed themselves to beginning training. There was one program already underway at SIM Gulmi in Niger, but that soon closed, and the first successful program was actually by Dave Thompson at Bangalo Evangelical Hospital in Gabon. This picture is from 1998. Next slide. The vision for PACS is African surgeons who live the gospel and minister to the sick. Next, please. PACS exists to train and disciple African surgeons to glorify God and to provide excellent, compassionate care to the most in need. Next, please. PACS is one of those groups that consists of Christians training Christians. Therefore, discipling is a major emphasis for us. We are not attempting to create medical missionaries per se, although we'd be thrilled if they actually decided to listen to God's call, but rather we are trying to train surgeons who live out their love of Christ as physicians in the community and lay leaders in the church. Next, please. PACS is a rural-based training program that uses established mission and church-owned hospitals. Next, please. The programs are directed by experienced board-certified surgeons. It's a 5-year competency-based training program. Looks very much like a 1970s American general surgical training program. It has, however, a very active component of discipling. It has academic oversight by Loma Linda University, and it actively partners with the College of Surgeons of East, Central, and Southern Africa. Next, please. We had originally planned, next slides, please. Next things, please. Go through all of those on that slide, please. We had originally aimed to train just general surgeons, but it became obvious that we needed to expand into subspecialty training. Presently, we have 16 programs at 10 centers. You can see that there are 10 general surgical and then pediatric general surgery. But we now have 3 orthopedic programs, 1 head and neck program, and a cardiothoracic surgery program, which is actually the first in that part of Africa. Next, please. The next several, please. The Lord willing, we're going to have 6 more programs added this next January, with 1 more planned for 2022. Next, please. This is where our present programs are located. You can go through, quickly add and populate that diagram if you would, please. We are excited. What we would really like, however, is a program in every one of those countries, one that will train general surgeons and other specialties and disciple them for Christ. Next, please. This is a graphic representation of the growth of PACS. You can see that we've had a kind of continuing growth. Of course, there's a lag time for the first several years because it takes a while to get somebody through the program. And this emphasizes what we were talking about. It's not easy, and patience is important. Next, please. About 18 years ago, next, please. About 18 years ago, people began to talk about the idea of training 100 surgeons by the year 2020. That goal was accepted formally about 15 years ago, but we really thought it was what Porras and Collis called a BHAG, a big, hairy, audacious goal, something that was absolutely ridiculous. At the time that we said we were going to train 100, we had 4, and we had 2 programs. It was never going to happen, except God made a difference. Next, please. Here is where our PACS graduates are working now, all of the yellow, and we would love for the entire continent to be yellow soon. Next, please. With the exception of 1 graduate, Martin Sally, who died in 2014 of Ebola, all of our graduates are still working in under-resourced areas, sometimes urban, sometimes rural, but certainly under-resourced. About a third of them are now spending a major part of their daily lives involved in medical education in some way. That's either from medical students all the way up to residencies. And in January of 2020, just a year and a half, 6 months ago, we opened our first program that's run entirely by our own graduates. So we're excited about that possibility. Next, please. In reviewing this, Dave and I found several things that we thought characterized the growth of PACS. And are things that I think organizations, if you're thinking about starting a program or being involved with a program, these are principles that are important. We have maintained a clear focus and certain principles. We've stayed true to those guiding principles. And I think that's one of the reasons that we've avoided the problem of mission drift. Mission drift is when you start doing something and it starts to wander off. Certainly, we're all familiar with hospitals here in the United States that have a Christian name in them, but are no longer Christian. So it often implies, however, that it's lost its Christianity, but it can also mean that it no longer stays with its core competencies. Each organization can do 1 or 2 or 3 things very, very well, but if it tries to do too many things, it can get lost and become inefficient. One of the things that we have realized is that this ministry is God's. It is not ours. Secondly, we are intending to create Christian surgeons. We are not insisting, as I've mentioned, that they be actual missionaries. We are emphasizing the spiritual training of our residents, but we're not trying to train great theologians, but we do want to produce leaders of our local church. We know that our core competencies are these 3 E's. We want to stay focused on evangelism. We want to stay focused on excellence in the surgery that we practice and teach. And we want to stay emphasizing education. One of the problems that you can get into is that as an organization sees all of the needs in of a country or of a people group, you can get into the distraction of doing good and avoid doing what is best. We can't solve all the infrastructure problems of all of the hospitals of where all of our graduates are going to work. So it'd be good for somebody to address those, and we'll be glad to partner with you. But our calling is to educate. not to necessarily change all of the problems with the infrastructure. It's important as you align yourself with an organization that you agree with and understand what they're doing and making sure that that's going to work for you. Next, please. Henry Blackaby had a wonderful book, Experiencing God, that I can certainly recommend to you. And one of the core messages that he brought in that study is that we should find where God is working and then join him there, not expecting necessarily God to bless our ideas, but to do the reverse, find out where he is and go sit at his feet and do what he wants us to do. PAX is actively sought to find God's direction and following his leading. We trust him to supply our needs in his timing and without relying on our cumulative wisdom as to the next step. We try honestly to write our plans in pencil, and we trust that God will not laugh too hard at our paltry efforts, and then we try to be sensitive when he is leading us somewhere else. We want to honor Christ in all that's done. PAX is trans-denominational. We work across multiple denominations and multiple faith groups. We work across the entire breadth of the universal church with multiple groups and denominations, and that sometimes is a problem. We do insist on unity and truly core beliefs, and we think those core beliefs are defining what we would consider true biblical Christianity with a high view of Scripture. But we do try to show grace for denominational differences and focus on a commitment to the Great Commission. We expect the Holy Spirit to do his work. We'll do our emphasis on what we are trying to learn and what we are trying to teach. Next, please. When we started thinking about this, and through the 25 years now that PAX has been existence, we've had to figure out there are several basic questions that we had to ask that'll define the organization. And any new organization or any new educational organization is going to have some sort of answer to these questions. Number one is, are we creating an apprenticeship or a residency? A lot of medical hospitals in Africa, in the mission world, have created apprentices frequently. They teach a few people to do things like I do them as I teach them. That is not the same as a residency. The apprenticeship trains people to do it in the way that the teacher does it, and a residency is actually trying to train to some standard that is recognized by others. Now, an apprenticeship is a lot less work, it's a lot less expense, but one of the problems is the alumni from that organization or from that training program are rather small in number, and they're limited as to where they can work and how they're going to be recognized and if they're ever going to get board certification and that sort of thing. Now, a true residency is a lot more work. You have to have a standardized curriculum, you have to have established of all sorts of metrics, you have to have a formal assessment process, you have a lot more external faculty support. However, it is the best way to ensure that the graduates will be recognized and that they can work in every place in their own countries. The second question that we had to come up with is permission or forgiveness. Now, getting permission to start a training program can be very frustrating and very time consuming. The necessity as to whether you need that is going to be dependent on the quality of the medical infrastructure within the country. I am honestly not sure that we could start PAX in the same way that we did 25 years ago, when we basically went ahead and started and then thought we would get forgiveness. Increasingly, we're having to have permission. However, looking at programs that have started for the permission and in our own experience, it certainly drags it out for years and years and years. It's a lot easier for a bureaucrat to say no than it is to prove something that's new and different and might get him in trouble if it doesn't work well. However, you do have to be aware that if you fail to get approval before starting, you do run a very real risk of bringing shame to the name of Christ. If you do this poorly and they are upset with you and things do not go well, this is not honoring to Christ's name. But in either case, what is very, very important is for you as a medical educator in that country, as a missionary surgeon or missionary physician in that country, to build relationships with the important people in your specialty in your country. A lot of times medical hospitals in third worlds have decided to kind of stay low so that they don't get on the radar, so they don't have problems with the government coming in. But this has caused us a great difficulty. We're unknown, and many things in the developing world are done on relationships. And so you have to build those relationships. If you're not going to get permission first, then the trainees are going to have to realize and be fully aware that may do the entire work. They may gain the skills, but they're not going to get the recognition. So they have to realize that they have a clear personal call from God to be involved with this. They have to be able to avoid bitterness if the later trainees get recognized and they never are able to. It's kind of like the folks on the first beach on Normandy. The death rate is high, and yet without them, you can't ever accomplish anything. So they have to be aware of this. And they have to also be aware that they may not have the same extent of employment opportunities that you might have should you be able to get into a residency as well. Now, the other question that comes up is this idea of professional, and are we creating professionals, or are we going to try to create task sharing? Task sharing is a term that came out of the HIV, and as you know, in order to get the healthcare out in the community, they would take lesser educated people to do certain tasks, and it would be hopefully under the supervision of somebody who is coordinating that. There is a great emphasis by a small group of people who want to train, for example, in surgery, want to train them to do certain procedures and let them go out and do C-sections and hernias and so forth, saying that some treatment is better than none. And there's some good data that says that you can do it, but they've run across a great number of problems in terms of the amount of supervision, whether or not they have a way that they can get employed, whether or not the government will recognize them and their professional things. How do you go through your job ladder and your career? So these are all factors that have to be considered as well. Certainly, the professionals are the high metrics, but there's a lot of money and a lot of time that comes into training folks. Next, please. I've labeled this slide the realities of Africa, but of course it's the realities of any undeveloped country. One of the issues that we had to struggle with is just the distance. It makes travel very, very expensive. Resident interviews are really not possible. It interferes with organizational cohesion because you can't get people together without tremendous cost and time. It certainly interferes with supply chains, having to wait for whatever you need to come for weeks or months. You are perfectly obvious to you that deficiencies in infrastructure are there, and that's at every level. At the medical level, you have the problem with the supply chain we've already mentioned. You have the issues of the recognition from the governments and from the American Colleges of Surgeons. Sometimes we just don't have enough Christians in the community to actually train of high quality who come out of residencies capable of doing what you need them to do. That's particularly true. We've had to close one program because in the entire country, there were only 50 Christians and not any of those particularly wanted surgical training. So it's something to keep in mind as you look at this. Hospital manpower is a problem. Having enough viable hospitals to work in is a problem. Adequate anesthesia providers, and that list can go on and on and on. Now, at the hospital level themselves, we have a problem that you have to have enough housing for the residents and the faculty. It takes money to build that. You have to have adequate numbers of both long-term and short-term, have enough faculty because of the turnover that goes along with that. In most of the programs, you get some of your training from some various specialists, and you may have a hard time finding the specialists you need that would help train. You won't find rotations in rheumatology or nephrology or in surgery. You might not find them in urology or neurosurgeon. So, that's an issue. Now, we underestimated as well the importance of our surgeons having academic experience as well. All of our surgeons came out and they love to teach at the bedside. But running an academic program is not just bedside teaching. It's all the other things. How do you handle difficult residents? How do you look at the metrics, et cetera? And so this was a problem that we had. And so sometimes in our excitement to get a program started, we overstressed our faculty tremendously. It turns out that the average medical missionary, the PRIME study from several years ago, showed that the average medical missionary really is only about a 60% FTE, because by the time you add home assignment and all his other responsibilities, he's only working about 6/10 of a real career. And so what that means is if you have 3 surgeons or 3 physicians who are there working as educators, there are really only 2 of them. And that can really add a significant stress to folks. We also realized that record keeping research capabilities, something that was important in medicine today, were problems. We didn't have electronic medical records. As a matter of fact, many of the patients took their charts home. And so there was no way to do decent research as well. But the problem with electronic medical records is that they're expensive. Everybody knows about the hassle of that in their hospitals. And for mission hospitals, they often don't have either the trained people to keep them running or the money to spend to actually get these as well. Utilities and internet, as you know, the average voltage is supposed to be 240, but we've all been in situations where it's somewhere between 40 and 440. We've had problems with water. We've had water problems with that. We don't have internet bandwidth. That's a real struggle, especially nowadays as we try to educate. Some of the other realities, we have partnership problems. Nobody is big enough to do this by themselves. So you partner with a lot of other groups. You partner with the local church. You partner with the whoever's running the hospital. You partner with denominations. You partner with colleges of medicine in the countries. You try to partner with the and so anytime that you add another group of people to partner with, the interactions become logarithmic in their problems as well. But this is important. One of the things that we've ran into is that the African hospitals that we're working with are often owned by the churches themselves, and they don't have the same perspective on the role of theology of mercy. And so if they're doing it basically so that they have a money source, a milk cow for their hospital or for their church, then they're not going to be willing to spend the money to either to reinvest into equipment and supplies and buildings that you need. And likewise, they will not be as willing to take care of the patients who are indigent, who are in desperate care of need. And so this is something that you have to address as well. The other problem within any kind of, partnership is that you have all those different interactions that are problematic. And so trainees, trainers, national physicians, expatriate physicians, et cetera, et cetera, et cetera. Next, please. These are 2 books that I would recommend to you. One is by Judith Lingenfelder called Teaching Cross-Culturally, and the other, that's a Christian orientation. And the other is Teaching Abroad by Sluthaug, rather, and that is a non-Christian. But both these will teach you a little bit more about this. There's a lot of forces at play in the actual process of teaching. If you're coming to these countries from the global north, you have often certain expectations about the preparation, the mindset, the philosophies, and the previous training of the residents that you're going to see and work with. You're used to certain ingrained pedagogical methods, and you can really be discombobulated when what you do your best, it doesn't work, it doesn't motivate. Many of your students are actually ill-prepared factually, and they're weak in the critical thinking that we consider so important. They have come often from a program that teaches them to memorize, that teaches them to just regurgitate whatever the professor has told them. They've often maybe short on resources. And so they are not, we're trained from kindergarten on up to try to take fact A and fact B and make fact C. That is something that they often do not know how to do. Often as well, they have a cultural expectation that you will be respectful for the elders. And so whatever you say goes. And that doesn't work very well when you're trying to get people to think for themselves. Next, please. I've mentioned before that to fail to plan is to plan to fail. And this is true both at a personal level and an organizational level. Now, as Christians, I've heard many groups say, well, yes, but we have faith in God. And that is true. And it's important for faith to be part of it, both for your life and for the organization. Because by definition, the future is unknowable. But we have an obligation to do our very best to prepare, to do what we can to make sure that we are have done our share as well. You remember the old expression that chance favors a prepared mind. One of the things that's important are these. Every decision you're going to make in how you're going to structure this, who you're going to hire, how you're going to aim your organization, it's going to have a practical consequence. And you're going to have to think that through, because sometimes what happens is you make decision A and B and C and D, and then you find yourself in a place where you don't want to be, and it's very difficult to get back as well. If you just, for example, let's say that we're going to make this quote Christian. Well, that has very real and predictable consequences. It means that you're going to have trouble with funding sources often, that you're going to have conflicts if the government is going to try to control your training, and it may have political consequences that go along with that. So even that simple thing that for us might be straightforward is going to have and affect the organization as we go. You have to realize that training is expensive. It's a lot cheaper there than here, but it's still expensive if we're going to do it well. And it turns out that there are very few sources willing to fund Christian medical education. As I mentioned earlier, there's very few jobs that will pay you to go do this as well. And so personal commitment is critical. What that does mean is that your organization is going to be dependent on volunteers. And the problem with volunteers is that you have neither carrot nor stick. You're not going to be able to force them to do anything, and you're not going to be able to bribe them to do anything. And that's true all the way through the system, and that can have certainly significant consequences. The partnership is a very loose organizational structure, and by our very nature, PAX is a multi-denominational, multi-country, multi-agency, multicultural coalition. And that is complicated by the fact that God insists on using broken people to accomplish his will. So there are a lot of stresses that come in throughout this entire situation. The very loose organizational structure and the lack of clear lines of authority and accountability has caused us a great number of bumps in the road. We've relied heavily on those volunteers that I've mentioned and various partners. And those partners, for example, that are very active: CMDA, World Medical Mission, MEI, Northwest Mission Teams, MedSend, African Mission Healthcare, mission agencies, the African churches, the African church-owned hospitals, and a lot of others, all with their own agenda and all with their own plan. We have tried telling them we're the right one, but that doesn't always work, as you can imagine. Next, please. PAX was and is very much like herding cats. Or to change metaphors, we didn't have that carrot or stick I mentioned earlier. Nobody in our training program actually works for us. Even our residents, we provide money to the hospital so that they're employees of the hospital and not for us. And so we realized very early on that it was difficult. We couldn't bribe folks to get things done, and we couldn't give them enough gifts and enough money to help them do what they need to do. The best we can do was pray and appreciate them. If you're relying on volunteers to do a lot of this, they have other conflicts of interest, their family, their work, all the other things. And so even the best of good intentions often may not get the work done. They all have time and service issues. And the faculty issue is a difficult problem. It turns out that very few of our faculty have actually stayed for longer than 4, 6, or 8 years. Now, there are some who have, and the ability to teach has been one of the things they name as the reason they're staying longer than the average. But increasingly, we all have this idea that long-term medical missions means a career, but the truth is, it's never been that much of a case. And the ones that we think of, the Adoniram Judsons and the Livingstons and some of the other more modern folks, the Sturries and so forth, they are an exception to the rule. Most people don't make it for a lifelong career. And so one of the problems that we find, and is a big hindrance to the organization, is that the biggest problem is that God is a gentleman. He will not force you to obey him. And so people who are willing to be obedient and to stay for whatever time God has them is our biggest hindrance. to recruitment. You're often asking in missions for non-academic physicians to be academic, and they often have a large number of conflicting chains of command. They have their family, they have their church, they have their sending agency, they have their hospitals, they have their African denomination, their family. And so this is going to be a situation that you have to keep in mind. And of course, the other very real reality is that burnout is a major problem in medical missions. Next, please. So you all probably recognize this famous scene from the Wizard of Oz, where don't look behind the curtain. The wizard, what's the wizard doing behind the curtain? I wanted to take a few minutes today to just talk about what we in PACS have struggled with as we go. Next slide, please. We had a business model that was unique. We've never done it before. The reality was there are more reasons to fail than to win. And it's a concept of medical education that the average person in the average pew or in the average foundation doesn't understand. And we started with a poor academic legitimacy, and Loma Linda University has been important to that. So these are all factors that you're going to have to consider and have a solution for as you go. Next, please. We've managed to make it, and we've made some mistakes. We've been too eager to approve some training sites. We accepted places that were not ready. We didn't have enough good relationship with national societies and governments. And of course, our vision was very limited. We originally thought it would be general surgery, and it's not. It's going to be a lot more than that. Next, please. We had to close some programs. We have struggled with that. These were closed primarily because we didn't have enough people and because we didn't understand some of the things that we've talked about. Next, please. We've struggled with the idea of good trainees. Our attrition rate is only 13%. That's actually better than it is in the United States, but it's a problem. You hate to waste the money. You hate to waste the time when there's such limited opportunities. There is also, we've struggled with how to disciple. We've had the problem with making sure that the residents' wives were taken care of. And we've struggled with the fact that once they've graduated, what are they going to do? Next, please. I'm going to talk just very briefly here as we come to a close on what you can do to become individually successful. Enhance your teaching skills. Every time you have a chance to be involved with teaching in some sort of formal or informal committee, do that. Some people ask about what specialty. The real specialty is what God's called you to. There isn't a single one that is better. What you want to do is what God's called you for. Look at the possibility of further non-medical training. Consider a master's in public health or a master in education or a master in business administration or those kinds of things. When you are doing a fellowship, try to get an academic position during that fellowship so that you have this credibility. Next, please. Enhance your own personal skills as you're going along. Mentor other folks, teach other people, any skills, work on this as well. If possible, use your time to get another language and as many cross-cultural experiences as possible. You don't have to cross the sea to get cross-cultural experiences, but make that a priority. Work on your own biblical training, your own spiritual health. Take a course in basic theology, a review in systematic theology, or a course in the New Testament or the Old Testament. Work on your family leadership because you're going to need those skills. Work on your church relationship because you're going to need those people. Next, please. Keep your when you're overseas, particularly, keep your CV and your resume up to date so that you can go back and get a job. Make sure you maintain your state licensure and your board certifications. I've seen missionaries who failed and then scrambled trying to get a job when they get back. Maintain your CME. Attend these webinars. When you're home, make a point of working in the United States, because if you haven't worked in the United States in 3 or 4 years, you can't get a job nowadays. And so it's important that you keep those skills and those connections. Teach and teach and teach. And when you're overseas, look for writing up cases and studies and do a research kind of thing there's still information that's coming out of the developing country that are changing how we affect things in the United States and Western Europe. Next, please. And that's it. Do you have any questions?
All right, let me start over. I think I was muted. Dr. Steffies, thank you so much for a great presentation. You have certainly contributed much to medical education in sub-Saharan Africa, and I thank you for that. And yeah, I just want to thank you especially for your work in PACS. I'm just thrilled with the progress that I've seen with PACS over the years through your efforts with first Dr. Thompson, yourself, and now Keir Thielander and so many other people that have contributed to that. Just waiting for a few questions here. Don't have any yet. I'll just speak on a few points that you made. Just this morning, Bruce, I heard Dr. Furman, the co-founder of World Medical Mission. He spoke about the Rebecca principle. And it's really just that principle, of course, comes from the Bible in Genesis, how Rebecca did more than she was asked. And I think that's really been part of the success of PACS in medical education. You talked about core competencies and excellence. Ken Isaacs always talks about the quality of our work as a platform of our witness. And I think PACS has really been largely successful because of that core competence of excellence. I've worked firsthand with a number of the graduates from the PACS program, and they just do a phenomenal job, Dr. Steffies. They represent PACS so well. In fact, the speaker for next month's webinar, Dr. Limfuka, is a graduate of your program, and I think he speaks very well to the excellence of your program. So just congratulations on that. And I think that program really, the PACS program also just really epitomizes what medical missions today should be all about. It's just so exciting for me to see what you guys have done in training up Africans really to be missionaries to their own countries. And I think that's the way it should be. And it just enhances our experiences on the mission field as we work cross-culturally with so many other people. So thank you for that.
Dr. Fuller, just yesterday, I received a notice from one of the missionaries in Tanzania, and she is very concerned that the politics are such that expatriate missionaries will be kicked out of that country. And so in terms of medical education, at least, one of the things that's nice is actually some of our graduates are now on the academic staff there and are of the caliber that they can take over and make a difference. And so while only God knows what he has planned for the future, I think that's one of the most exciting things, is knowing that you've left something. And sometimes leaving something is actually with the missionaries themselves, because if I go over as a general surgeon, I'm not really good at orthopedics or these urology. And so short-termers coming through World Medical Mission can teach me every bit as well as they can teach the residents. But when you leave, you can go home and leave something that's there that will make a difference. I ran into a surgeon several years ago who was from a small town in Iowa, and he was there a couple of weeks before me. And when I talked with the residents, they said, well, Professor so-and-so said it was thus and so, and it was just exciting because I know for a fact that he would never consider himself a professor in the classic sense. Mm-hmm. But to these young men and women, they had listened and made a difference. And so whenever we teach at whatever level, we're making a tremendous difference. And then if we can do that, showing them what a Christian physician, what a Christian surgeon looks like, then that makes all the difference in the world. The College of Surgeons of Eastern Central and Southern Africa right now are very concerned that they're training people without integrity. And so that's an issue where we all can have a role in that because we have our integrity directly from Christ.
Okay, awesome. Thank you so much. So actually, Dr. Steffes, we do have a question. What would you consider to be a minimum number of faculty to initiate a residency program at a single site? Like, in other words, what full-time equivalents?
It would be 3 really, truly full-time missionaries who are 0.6. So the answer is that's only 2. So if anybody gets sick or you have a family issue, even that's struggling. So 3 is the bare minimum. 4 is better. And it would be 4 plus an administrative assistant would be better yet. Someone to run all the paperwork, do all the record keeping, keep the residents up to snuff, et cetera.
Right. Awesome. Yeah. Bruce, one of the things you said as we wait for any other questions is just you said that God uses broken people. And I just like to emphasize that, as maybe our listening audience ponders, or considers a career in academics and medical missions. I think so many times we think that we're inadequate to do the work that God has for us to do. And I think the availability is and a calling, of course. But I appreciate, what the way you said that we can prepare ourselves to serve. And, God can use any of us to do this work if we're called to do that and we make ourselves available. So thank you again for what you have done. And also just want to emphasize, you really brought up the point about volunteerism. World Medical Mission is all about medical volunteers. We rely heavily on volunteers. And so just an appeal to our listening audience, consider some of the things that Dr. Steffes has said in terms of considering being involved in something like PAX or World Medical Mission, availing yourself just to offer your medical services and to contribute to teaching in the developing world, if you will. So, Dr. Steffes, I think that is it in terms of questions. Wait a minute, we may have one more for you. Just 1 second. One last question, and then we'll draw it to a close. It says, do they have any medical training before the residency, or is the 5-year medical and surgical training? Is the PAX training it?
One of our requirements is that they have a full medical diploma from their local schools. And almost all countries require a year or 2 is an unmonitored often internship, working as a medical officer. So most of them have 5 or 6 years of training. But in a paradigm where students are often left on their own, it's sometimes frightening and so one of the problems that we actually learned in surgery is that we had to take people who did not have a lot of experience after medical school because they had more things they were doing wrong than we could correct. Yeah. And so we try to get them very early on in their training so that we start with the proper techniques.
Yeah, I think in general, correct me if I'm wrong, Bruce, but what generally happens is a lot of these medical programs, they have a lot of classroom and academic training, but they don't have a lot of hands-on practice.
That's correct.
And that's the beauty of PAC's program, is it takes these people that have been, prepared maybe in the classroom, but this really gives them opportunity to develop themselves as a true surgeon, to get real tremendous practical experience. And these surgeons, when they finish, are very, very gifted. So that's it. Again, Dr. Steffes, many thanks for your preparation and your time here today. To our listening audience, thank you for joining us. Remember that CME credit is available for the session. The form and instructions will be provided to you in the email you received. And we will be sending in the next 24 hours, give or take, a follow-up email with a link to this recording. If you're not on our email list, you can join the forum at health.samaritans.org and just learn about upcoming webinars and other events, medical events with Samaritan's Purse. Our next webinar will be Wednesday, October the 14th. As I said, it'll be Dr. Duodane Limfuka, a graduate of the PACS program, and he's going to be speaking about training Christian surgeons, an answer to the huge need in Africa surgical workforce. So with that, thank you again for joining us. God bless your day. Take care.
Thank you.